where we aim to present some difficult situations that we encountered during vitreoretinal surgery. We have an extremely erudite panel. Dr. Lingam Gopal will join us shortly. As Dr. Vatsal Parekh, Dr. Lalit Verma also is expected, Dr. Karobi Lahiri, Dr. Ashish Vaidya, Dr. Preetam Samant. All of them are extremely big names and extremely good vitreoretinal surgeons in their own various ways and need no introduction. So let's get on with the first case. Is a patient being presented by Dr. Preetam Samant.
So this was a patient of a shallow retinal detachment. Now, to add to my misery, this patient was a high myope. The patient has albinotic fundus. So he had a very localized retinal detachment in the inferotemporal periphery. No, go back. And a young patient, 22-year-old female. So now go next. So now this is how the fundus picture was. There was a retinal detachment here. I thought I saw two breaks, confluent breaks over here. It's a very shallow retinal detachment. So at this stage, before showing the video, I would like to ask, what could be the situation or the possibilities? How would you deal with? Obviously, you would plan a buckle here. The young patient, inferior detachment. What I thought was maybe I would get away with a non-drainage buckle also because it was a shallow retinal detachment. So, shall we go to the video?
Dr. Gopal sir, please come to.
Go next. So my options I thought could have been a non-drainage buckle. I thought I'll tighten the buckle, then decide whether to drain, or if it's not responding, then worst scenarios convert to vitrectomy. And obviously cryo while doing buckling. So these are the thoughts which were running in my mind before I planned the surgery. Next.
Here I just put in one more spanner. Sir, would the old time diathermy have any role whatsoever in an albinotic fundus? Most of us do not have access to it any longer, but just for theoretical purposes, sir. This is an albinotic, young albinotic female with shallow retinal detachment, high myope, and this is the configuration. These are the two breaks which are suspected on clinical examination, and the possibility of non-drainage.
Why you think cryo would not work in this case or laser would not work? Because we should understand that albinotic fundus doesn't mean there is no retinal pigment epithelium. It is there. It just does not have melanosomes. That doesn't alter the reaction of the retinal pigment epithelium to the laser, except the absorption is much, much less. We do understand both diode and green laser are absorbed mainly by the melanin pigment. But despite the lack of visible melanosomes, even albinotic RPE does absorb some laser energy. So you will get light burns, and that is enough to cause a chorioretinal adhesion. And for cryo, there is no problem with RPE at all. And so cryo is absolutely fine in case of albinotic fundus. So there will be excellent adhesion that forms between the two.
So, when I was trying to localize, I was unable to find the break because of the albinotic nature of the fundus. So I thought I'll use a chandelier. So what I'm doing here is using a chandelier for visualization, internal visualization. You can see I've put a chandelier here. And on chandelier, I am able to localize the breaks. See two small breaks in the corner here. This was maybe the first time actually I was using a chandelier when I was faced with this situation. But I think it's an excellent method for buckling, scleral buckling. Here you can see I'm doing cryopexy. You will be able to see a silhouette of two breaks soon. And it was a shallow RD, and since the retina didn't drape itself on the buckle, I proceeded with a laser drainage for the choroidotomy. And drained the fluid here. It was pretty viscous fluid because of a long-standing nature of the RD. And then put the buckle, sutured the buckle and tightened it. So this is just something which different I did from a routine buckle I normally do. So that's about it.
Do the panel-
I'm checking with the chandelier the height of the buckle and the position of the buckle.
Does anybody in the panel have any additional comments to make in this?
Preetham, when you depress, usually you see on depression the age of the break. So I think how would it differ in albinotic fundus? Because when you depress, you will see the age, and probably when you do cryo in suspicious area, you would probably be able to identify the break in silhouette. What
Yeah,
do you
I-
think, sir?
Yeah, I'm sure, but in this situation, I was not able to see the break. Maybe in the past, I would have cryoed the entire periphery of the detached RD. Maybe that was the other option.
You could see it preoperatively, right?
In the preoperatively, I thought I saw the breaks there. If you see, I
Yeah,
put a
and
question mark.
if you saw preoperatively and you can confirm it in slit lamp biomicroscopy, because very often we ophthalmologists don't use all our tools to our best advantage. I think it's important that we should be able to use both indirect ophthalmoscopy and slit lamp biomicroscopy to our advantage. And there are one group of people who use only indirect ophthalmoscope, the other who use only slit lamp biomicroscope, but we should use both together. And if we do that, what you suspect with the BIO, you can definitely confirm with slit lamp biomicroscopy, even if you can't see it easily because of sheer magnification. And once you identify it, doing a detailed drawing is probably very useful in this kind of situation where intraoperatively your visualization is not as good as preoperatively, and use that as a roadmap, locate the area of suspicion, and then treat with cryo. So we can manage with indirect ophthalmoscope also. I'm not saying there's anything wrong in using his technique, it's absolutely fine. You give higher magnification under microscope, so you're able to see it better, no problem about it. Except you're entering the vitreous at one point, that's still okay, no problem. But this is another way of doing it, is doing a more diligent preoperative workup, using both tools, do a detailed drawing, put the drawing next to you, and do slit lamp biomicroscopy and add to it, add to the indirect ophthalmoscope drawing, so that each curve is nicely depicted and your break is depicted next to a good landmark, and then use that during surgery for identifying the break.
Any comments about the laser drainage as against using a sharp pointed 23 gauge cautery
I
to
think
cause a...
laser drainage is a good technique because most importantly you're not entering the eyeball with any instrument. So, and it cauterizes the blood vessels as it penetrates, so the risk of subretinal bleed also is much less. So I think laser drainage, if you have the facility to open the laser probe and the laser machine available in the OT where you're doing the buckle, that's perhaps the best technique. You can in fact use it for every case if you wish to, no problem. I would think that's excellent technique.
What about non-drainage, because it's a shallow detachment?
Yeah, so that was another advantage of the this chandelier. I feel it can give you a better view inside. Because when I tightened the buckle, the retina was not draping over the buckle to my satisfaction. I knew there was fluid over it, so that's why I thought I'll go ahead with and drain it.
Preetham, next case.
This is the next case. Now here I'm dealing with a retinal detachment with dense PVR. I've separated the PVR and I've done a 360-degree retinotomy. I've cauterized 360-degree in a usual fashion, and then I find that this superotemporal edge somehow is rolled up really severely, and I'm faced with a situation where I would have to cauterize it so much that it would really bring the retinotomy close to the arcade and to the posterior pole. So you can see this is the edge here, which is completely rolled up. Now in the rolled up edge, otherwise I would left with the option of cauterizing from the back of the retina, but I felt that was a little risky doing that. So this was the situation that I was faced with.
So what would the panelists would have done in this kind of a situation?
The PFCL probably I would massage the area.
So just before, I even tried my PFCL. I put overfill so that the PFCL would go over the edge, and it was rolling under the PFCL also. It was that rolled up.
So probably then endodiathermy and removing that area would be the only answer according to me, sir.
Yeah, I mean that obviously means that area of retina is still contracted, and you have removed all visible membranes, and yet it is contracted, and you have to excise it. That means your amount of retinectomy was not enough. That's what it means. So if your PFCL is rolling on top of that fold rather than flattening it, it's a clear indicator that that part is contracted. It has to be excised. I would excise it. in that extreme periphery, if you exercise that strip, you're really getting rid of all tissue which is contracted, anomalous, non-functional. If you're making radial cuts, yes, you can theoretically fix the retina, no doubt, but you're still retaining that area of contracted retina between the radial cuts. So there's always a possibility when you're removing the oil, it may still be a cause for recurrences and all that. Why not we exercise it? After all, up to equator, it's perfectly fine, because that amount of peripheral retina you're able to sacrifice without compromising too much on this field of vision. I understand if it is very posterior, very close to the posterior pole, you hesitate, you have to exercise the retina, but this is quite far in the periphery. That should be okay. It's always like that monkey and the bread story, how much to cut, you keep pinching here a little bit, pinching a little bit here. So instead of doing that, you plan nicely and exercise of a decent part of the retina which is absolutely sick and contracted. Then in one go you fix the retina, you don't keep on going back and forth. Because when you're hesitant to exercise the retina, that's when you keep going back and forth. You inject a little PFCL, you're not happy, or PFCL starts going under the retina, then you say take out the PFCL, again try to cauterize, exercise a little more, then again inject PFCL. This back and forth, you not only waste time, it traumatizes the eye, and some PFCL gets trapped in the subretinal space, and those bubbles go into subfoveal location postoperatively. These are all issues. So best is to plan in advance what is the area of contracted retina. With expertise, with experience, you realize this part of the retina is not going to settle. Just exercise it off, nice and clean. And as Dr. Karobi said, circumferentially, you err on the side of being a little more than.
And one important thing in 360-degree retinectomies is before you cut off the last bridge of tissue to the bridging it to the peripheral retina or the ora, you inject PFCL and get the macula and the fovea in position. Otherwise, you'll have a situation where in these kind of cases there will be contracture around the nerve and you'll have a dislocated or a rotated macula.